Hey everyone, we're going to give folks just a few more minutes to roll in and we'll get started. Thanks for joining on time.
Is no. So I'm just gonna take over the secretary duties. We were all born in it.
All right, can everybody see me, hear me, see my slides okay? Somebody speak up or throw a yes in the chat or something. Let's see. Okay, perfect. Thanks, Ginger. All right, let's go ahead and get started. So today I wanted to talk about decompensated cirrhosis. So this was actually our very first new report topic like a year and a half ago. But wasn't a lot of people that made that, and I wanted to record it so we could upload it to our YouTube channel. And I've modified the presentation a good bit. Also, I think it's a topic that most of us kind of struggle with, so I thought it was worth repeating. So let's get started. I've got no financial disclosures. In terms of objectives, so just kind of quickly, we're going to talk about what decompensation actually means. We're going to discuss variceal bleeds. We'll talk about TIPS procedures. We'll go over SBP, we'll go over HRS and hepatic encephalopathy. So kind of all the big stuff regarding decompensated cirrhosis that I think we don't always treat as well as we should. So, okay, so before we kind of launch into an entire presentation on decompensated cirrhosis, let's talk about what that actually means. In short, if a patient is having symptoms from progression of their cirrhosis, they're classified as decompensated. So technically, it's a cirrhotic patient that experiences jaundice, bleeding, ascites, or encephalopathy. So if you just carry the diagnosis and the diagnosis is based off of imaging, and you're otherwise doing fine, you're compensated. But as soon as you start to show really kind of any symptom related to the cirrhosis, you're then into that decompensated bucket. Okay. All right, so this is going to be kind of a case-driven lecture. I also kind of want it to be interactive, so y'all please weigh in if you can. If not, there'll just be a lot of awkward silences before I give you the answers. So let's try to make this a little interactive if you're in a place that you can do it. So here's our first case. We've got a 55-year-old male. He's got a past history of hep C and alcoholic cirrhosis. Who comes into the ER. He's brought by his wife with concerns for altered mental status. So immediately that should start, sending you down a certain pathway and should start bringing other questions to mind, other scenarios to mind, other precipitants to mind. This is kind of like line one of your illness script, right? So if this is all the information you have, if the ER calls you and gives you this one-liner, what else do you want to know about this guy? So not labs or imaging, but just really from a history standpoint, what other questions would be important at this point?
What medicines he's on.
Okay.
I'd check a UDS to see if he uses any illicit substances.
Yeah. Okay. Thank you, Ginger. Anybody else? We've got an altered cirrhotic.
The duration of his symptoms.
Mm-hmm.
Had he been sick at all before he became altered?
Yeah.
Has he been taking this
If he
medicine?
has a history of any other kind of like decompensation, varices, things like that, and noticed any bleeding.
Yep. Yeah. So cirrhotics often get what we call Higgia. Higgia. That's what Dr. Sad had it before, got it again. So if they've had hepatic encephalopathy before, they've had bleeding issues before, odds are it can happen again. So fortunately, this patient's wife is at the bedside and she provides a little bit more history. And she says that in addition to his worsening confusion, she's noticed that the patient's been vomiting some blood and his stools may have been darker over the past week. Okay. So let's take a look at some vitals and his exam. So he's a little tachycardic, a little hypotensive, afebrile, O2 sats are a little on the low side, but okay. He's got jaundice on exam. He's tachycardic. He's got a soft, non-tender belly, and he's really difficult to arouse, and he's not alert or oriented at all. Okay. All right, so let's look at his lab sum. What stands out to you guys here? Which of these labs kind of gives you more insight about what could be going on now, what could be going on long term in this patient? There's several things here that kind of stand out to me. What stands out to y'all?
He's anemic. He's hyponatremic. Bilirubin, if we had to compare what it's been previously, INR and albumin.
Yeah, anything else from anybody? Thank you, Ginger. Okay, so the labs aren't red like they are in impact when they're abnormal, but several things here kind of point out to me. As Ginger mentioned, his low albumin and high INR kind of in a vacuum give me some idea that this patient probably has advanced liver disease. Now, maybe you can make the argument he's just a bad alcoholic and he drinks all his calories, so he's malnourished, but the low albumin, the high INR tells me the liver is probably not functioning very well. So those two labs in and of itself tells me he's probably got advanced disease. His hyponatremia is pretty concerning to me too. Now, there's lots of reasons for hyponatremia, but hyponatremia in a cirrhotic patient is always concerning to me. So it's always kind of a marker of worsening disease. And that's why it's incorporated into the sodium MELD score. So patients with cirrhosis have problems with systemic vasodilation, which we'll talk about later. But this vasodilation kind of results in a lower intravascular pressure, lower mean arterial pressure. That's going to activate our antidiuretic hormone, which is going to try to promote water retention to bring those pressures back up. And that water retention can lead to hyponatremia. While his creatinine is normal, his BUN is pretty high, much higher than what you would expect in somebody with a normal creatinine. So that, in light of this questionable history of a GI bleed, is telling. So blood has a lot of protein in it, and as the blood is digested, the different proteins are metabolized into urea, thus kind of resulting in an elevated BUN in the setting of a normal creatinine. So that whenever I see a BUN much higher than a creatinine, I'm thinking about blood within the GI tract. He's also got pretty significant thrombocytopenia. We see that a lot in our cirrhotics. Again, this is a marker of advanced disease. There's a couple of reasons for this. The liver makes the thrombopoietin, which is the protein that then goes and tells our bone marrow to make more platelets. And so if the liver's not functioning and making the proteins that it's supposed to, you're not going to stimulate the bone marrow to make the platelets. Also, obviously, these patients get really bad portal hypertension, which leads to splenomegaly, and then all these platelets get sequestered within the spleen. So we have a production problem, and we kind of have a sequestration problem. So even knowing nothing else about this patient, just seeing these labs tells me he's got advanced cirrhosis, and no matter what he comes into the ER with, he's got a pretty bad prognosis. These are all concerning. Okay, so let's kind of summarize this case a little bit, give us a one-liner. We've got a 55-year-old male. He's got advanced cirrhosis, comes into the ER with altered mental status, hemoptysis, and melena. All right, so let's talk about our initial management. So as we know, cirrhotics can get very sick very quickly. The first thing you gotta think through, is he stable? Looking at these vitals, I'm a little bit worried about him. He's tachycardic, he's hypotensive, he's altered to the point that he can't provide a history. He's anemic in the setting of blood loss. He also has this leukocytosis. There's a lot going on that makes me kind of worried about this guy. Now, it's not unusual for cirrhotics to have a low baseline blood pressure, but in light of this tachycardia, that's telling me either this pressure is much lower than what he's used to, or his anemia is much worse than he typically is. So the heart rate is kind of concerning in the context of hypotension and a low hemoglobin. As with all your patients, don't forget your ABCs. You got to worry about his airway. Can this patient protect his airway? Is he so altered that he's not controlling his secretions? Is he having continuous hematemesis? These are patients you need to think about intubating if you need to. So circulation, we talked a little bit about his blood pressure being low and his heart rate being high. Before we do much of anything, we need to make sure that this guy has good access and start resuscitating him. So he needs crystalloids and colloids. So when it comes to crystalloids, we've had this kind of long debate about normal saline versus lactated ringers. Despite us internists kind of being married to saline for decades, most of the literature that comes out says LR is probably superior in most situations. And then colloids too. He's anemic, he's bleeding, he needs blood. That's not only going to improve oxygen delivery to the tissues, but it's also going to provide some much needed oncotic pressure. What about albumin? Don't want to call anybody out and ask if you would give albumin, but you shouldn't. Okay, so there was a paper that just came out in the New England Journal of Medicine that took a closer look at albumin. And this was a randomized trial that investigated whether or not patients hospitalized with decompensated cirrhosis should routinely receive albumin. Okay, so not in other situations in which there's evidence like with SBP, but should we be given albumin to all of our hospitalized decompensated cirrhotics? And the outcomes were virtually identical in those who received albumin compared to those who received standard of care. In fact, those who got albumin had much more serious adverse effects. So for routine decompensated cirrhosis, albumin not only doesn't help, but it probably makes things worse, and it's also incredibly expensive. So you shouldn't necessarily be given albumin to these patients without a really good reason. Okay, so we've stabilized them, we've given them some blood, given them some LR. Here's kind of our summary so far. Now these labs and vitals are from before we resuscitated them, but what other workup do you guys want at this point? What other labs? Any other questions? What other things are you thinking about? So again, we've got an altered cirrhotic that comes in with melena with these labs. What else are you guys thinking in terms of workup? And Ginger can't be the only one to answer. So.
Who's answering?
Sorry, what'd you say?
No, I said you can't be the only one that answers.
Oh.
Okay, well, since nobody knows, I will tell you what else I would want. You know, he's altered. Obviously, we're thinking about hepatic encephalopathy, but you know, not all cases of altered mental status in a cirrhotic are necessarily due to hepatic encephalopathy. So you know, probably need a CT head. You know, did this guy get drunk and fall and hit his head? We need to get a urine drug screen. Probably also need to be thinking about an infectious workup. So, you know, he's hypotensive, tachycardic, he's got this leukocytosis, and we can maybe explain away all those things, you know, with other conditions. But, you know, this is a guy that I want blood and urine cultures on, chest x-ray. And then in terms of his cirrhosis, you know, if he's got ascites, I want a diagnostic tap, which we're going to talk more about. What about anybody want to order an ammonia, or what about a hemoccult test? Probably not. Okay, so we're going to talk a bit about ammonia later on, but there was this really good article in the Journal of Hospital Medicine about hemoccults or fecal occult blood testing. So hemoccults have only been approved for colorectal cancer screening. Okay, that's the only approved indication. With some rare exceptions, we hospitalists don't really screen for colorectal cancer. So really, there's no reason we should ever order this test. Now, there's lots of scenarios that you can maybe think of where a hemoccult might be helpful on an inpatient, but the data shows that when ordered for non-indicated reasons, there's a very high incidence of false positives and false negatives. Okay, so don't order a hemoccult test. The actually the most important thing in getting an idea of a possible GI bleed is visual inspection of the stool by a provider. So this paper talks a little bit about that, but observed melena by a provider has a likelihood ratio of 25 for upper GI bleed. So a likelihood ratio tells you, how likely is it you can make a diagnosis based off of a particular test. That's incredibly high. Just to kind of give you some more context, performing a nasogastric lavage and seeing blood or coffee grounds through that invasive test only has a likelihood ratio of 10. Now 10 is still pretty good, but just looking at the stool is 2.5 times better, for lack of a better phrase, than doing an NG lavage and trying to determine if there's blood within the GI tract. So really, if there's any questions, a lot of times there's not a question, but if there's a question, take a peek at the poo, and that's going to be one of the best diagnostic tests that you can do. Okay, so we've stabilized this guy, and we've sent the additional workup that we've talked about. Based off of this patient's history, it sounds like we're possibly dealing with a variceal bleed. So let's talk a little bit about that. So first, we have to understand why varices form and where they come from. So as cirrhosis progresses, the liver is going to scar down, kind of become firm. Think of it like an old dried out sponge left in the sun too long, compared to a healthy liver, which would be a nice new plump wet sponge. As it's scarred down, it creates these external hydrostatic forces that make it harder for blood to flow through the liver. Okay, and as a result of that, as the pressure kind of builds up and it's harder and harder for blood to flow through, we start to have blood backing up and creating pressure within the portal system, the portal venous system, i.e. portal hypertension. That's not the only vein that's affected, right? So the portal system is going to drains a lot of different organs, so the stomach, the esophagus, the rectum, kidneys, the umbilical area, the spleen, and eventually the pressure is going to continue to back up into these organs. And these veins are not equipped to handle that type of pressure. Veins that drain the stomach probably live at a normal pressure of 5 to 10 millimeters of mercury, really low pressure systems. And so as a portal hypertension builds up and you're talking 20, 25, 30 millimeters of mercury, that's way much more than these veins can handle, and it can lead to rupture. Okay, so it's important to know with variceal bleeds, this is not a coagulopathy issue. This is a pressure issue. Kind of the liver coagulopathy doesn't help, but this is a consequence of pressures being too high for veins, and it results in venous rupture. Okay, so now that we understand where they come from, how do we treat it? Okay, so one of the most important things that we do for variceal bleeds is octreotide. So octreotide works by acutely decreasing portal pressures. It's going to cause vasoconstriction within the mesenteric vasculature, and that's going to reduce portal pressures. So as I said, variceal bleeding is mostly a pressure phenomenon. And so there are cases in which octreotide alone can actually stop a variceal bleed, just reducing the pressure enough that the blood starts flowing forward instead of backwards. And octreotide can be really effective in doing that. Okay, so antibiotics. We've already noted that this patient might be septic with this hypotension, tachycardia, leukocytosis, and that alone is probably enough for me to go ahead and pull the trigger on antibiotics. But even if we didn't have all those things, we know that cirrhotics who are admitted with GI bleeds are at much higher risk of developing SBP. So you're going to start antibiotics in patients in cirrhotics that come in with GI bleed. We also need to start a PPI. So like I've said, variceal bleeds are pressure phenomenons mainly, and then partially due to coagulopathy issues where they're having trouble stopping the bleeding. So if you know for a fact that it's a variceal bleed, PPIs actually don't have a role. The problem is when patients first come to us, we don't know if they're having a variceal bleed or gastric ulcer or some other etiology that a PPI will benefit. So cirrhotics get peptic ulcer disease too. So until you know for sure, you got to have them on PPI. Of course, once they go for their scope, if there's no, or if we confirm that it's a variceal bleed, a PPI drip plays no role. Okay. All right. So as a mainstay of what we as hospitalists do, the first three things really are key. But these patients need an EGD, and so we call our gastroenterology friends. This patient goes for an EGD, and this is what they see. So a nice, not spurting, because that would make you think arterial blood, but this is like you've left a water hose on. You have this continuous oozing from these portal pressures. And so for our patient, we started them on the right medications, and the GI doctors clipped the variceal, and so he's stable. All right. But how do we prevent this from happening again? We already know he's got portal hypertension. He's probably got other varices throughout his whole body. And so you need to be thinking about ways to prevent this from happening again. Okay, so we have a couple of different ways that we do that. Medications are really important. Most commonly, we're going to be using beta blockers, things like propranolol and nadolol, just like they work with throughout the rest of the body. They can reduce pressures within the vasculature. Okay. Surgery too. Okay. Surgery can be used to reduce portal pressure. What procedure am I talking about? A TIPS. So a TIPS is, just as the name implies, a transjugular intrahepatic portal shunt. So you go in through the IJ and put this shunt that is going to run directly from the distal part of the portal vein up to the proximal portion of the hepatic vein. And so what's going on here is you are bypassing all of that scarred down liver that we talked about. And so you've removed the external forces that's making it harder for blood to flow through, and it can now drain directly from the portal system back to the systemic venous system. Okay, so this is very effective at reducing pressures. The problem you run into with the majority of these patients is that even with advanced cirrhosis, the liver is still doing some metabolism, and it's clearing some of that ammonia. But as soon as you put this shunt in and you've got all the blood now bypassing the little bit of liver that works, you're getting no metabolism of ammonia. And so patients who get TIPS procedures are very prone to developing hepatic encephalopathy. Okay, so that can even be fatal. Post-TIPS, HE is often fatal. Patients develop other issues, and so got to be mindful of that and be cautious about when you pull the trigger on a TIPS. Okay. Okay, so let's change it up a little bit and go on to case 2. So this is a similar case. We got a 55-year-old male. He's got a past history of hep C and alcoholic cirrhosis, brought into the ER by his wife with concerns for ultramental status and abdominal pain. Okay, now in this case, there's no history of bleeding, no changes in his bowel movements, making a GI bleed a little bit less likely. But we've got the ultramental status and the belly pain. So here are his vitals and labs. Still tachycardic, but not as much as our last guy. Still a little hypertensive. Temperature is a little bit higher. Still has the jaundice. Kind of the big difference here is this patient has a really tense abdomen that's kind of tender throughout, and he's got this lower extremity edema. He's also disoriented, but not as much as our last guy. Here are his labs, similar, but white count's a little higher, platelets are a little higher, hemoglobin's a little higher, BUN is normal, but his synthetic liver function is about the same. Okay, so just kind of creating your one-liner. You got a 55-year-old guy, advanced cirrhosis, comes in with ultramental status and belly pain. All right, so what's next? What's diagnosis are you thinking about? What you should be thinking about is SBP. So take home point number 1. If you guys remember nothing else from this lecture, remember this. Any cirrhotic that comes in with ascites admitted with any complaint has SBP until you prove that they don't. Okay, if they come in with a hangnail, you better be thinking about SBP. Okay, I've made it a little bit more obvious in this case. He's got the tender belly, he's got a leukocytosis, he's got this borderline temp. It's not always that obvious. SBP can be really subtle, and if you miss it, patients die. Okay, so if you've got a cirrhotic on your service and they've got ascites and they're admitted to the hospital, you've got to be thinking about SBP. Okay, I'm not saying you have to stick a needle in every belly, but you need to be thinking about it, and you need to have a really good reason to not do it. Okay, so this guy, we're worried about SBP. To prove it, we've got to get a paracentesis, right? So how much fluid do you think we should take off this guy? So we can do a diagnostic para, which is really just taking enough acidic fluid to fill up a couple of test tubes and a couple culture bottles, or we can do a larger therapeutic tap and remove all this fluid to make him feel better. remember, a therapeutic tap is strictly for palliation. It's just to make a patient better. In this case, this guy's got a lot of ascites on exam, but why would we not want to do a large volume therapeutic tap at this point? You've got to worry about, what's called post-paracentesis circulatory dysfunction, which in a patient with decompensated cirrhosis can be fatal. So let's talk about what that is. So these patients have a really complex circulatory physiology, most notably the portal hypertension. And when they develop these tense ascites, the acidic fluid is exerting this external hydrostatic force on all the vasculature. So you've got all this ascites that's kind of squeezing all the veins, creating a positive pressure gradient. And so while we do have some fluid leaking out from the portal system where we wouldn't have ascites to begin with, a lot of it's kind of held in check by this external acidic fluid applying pressure to the mesenteric venous system. So if you remove that, if you stick a needle in and you drain all that acidic fluid, now you've removed that external force that's applying pressure to the veins. And due to the low oncotic pressure within the portal system, you suddenly have a lot of serum leaking out of the portal system into the peritoneal cavity. Okay, so when that happens, you get significantly reduced intravascular volume, hypertension, renal failure, death. It'd be really dangerous. Okay, so if the patient's unstable, never do a large volume paracentesis, get just enough fluid to do a diagnostic tap. And once he's doing better, then we can take off more fluid to help him feel better. This is the reason for the patients who we do perform an LVP on, we give them albumin to increase the oncotic pressure to kind of try to avoid this from happening. Okay, so let's go back to our patient. We think he probably has SBP, so we collected some acidic fluid for a diagnostic tap. What are we looking at in that fluid? What is it that we really want to know? For me, there are two big questions that we've got to answer. One, where's the ascites coming from? Okay. Two, is there an infection? The second one is critical. The first one is not always as important in most clinical situations, but it's something that I think about whenever we're doing a diagnostic tap. But you've got to ask yourself these two questions. So to answer the first one, we've got to talk about the SAG, which is the serum to ascites albumin gradient. That's calculated by measuring the difference between the serum albumin and the acidic fluid albumin. So if it's greater than 1.1, that tells you the acidic fluid in their belly is coming from portal hypertension. Okay. If it's less than 1.1, you got to be thinking about other reasons why patients can have ascites, nephrotic syndrome or severe pancreatitis or peritoneal carcinomatosis or all other things that can lead to ascites not due to portal hypertension. But if it's greater than 1.1, you've got portal hypertension. But that doesn't tell you it's coming from the liver. Again, there are scenarios in which you can have portal hypertension from another non-liver primary etiology, like severe right heart failure, right? So to determine exactly where it's coming from, you can check an acidic protein level. So if your acidic protein is less than 2.5, that tells you the portal hypertension is coming from the liver. If it's greater than 2.5, that tells you something post-hepatic is causing the portal hypertension. Now, we don't see that a lot, and usually it's kind of obvious from the clinical scenario. Does this guy have ascites? Is the ascites due from the portal hypertension? Is it due to liver disease? But if you're sticking a needle in them anyway, I get these labs just to make sure, because it'll tell you for sure exactly what's causing the ascites and where it's coming from. Okay, let's talk about how we determine if there's an infection. Okay, pretty straightforward. Check a cell count and a differential, and if you have more than 250 neutrophils within the acidic fluid, there's your diagnosis. Okay, so here's our patient. These are all the labs that we checked. Of course, you're checking the gram stain and you're sending for cultures, but these are the labs that are really going to tell you what's going on with the patient. So how would you guys approach this? So again, ask yourself those questions. Does he have portal hypertension? Yes, so his SAG is 1.6, 3.7 minus 2.1 is 1.6, which is greater than 1.1. So his ascites is due to portal hypertension. Next question. Is the portal hypertension due to liver disease? Yes, his protein is less than 2.5. Okay. And then lastly, is there an infection? The answer is yes. So 70% of 400 is greater than 250. So he's got SBP. So these, four labs here tell you what his ascites is coming, where his ascites is coming from, and it tells you he's got an infection. Okay, so treatment. The mainstay of SBP treatment are antibiotics and albumin. All right, so when it comes to antibiotics, there's a few things you got to think about. In terms of coverage, most cases of SBP are due to translocation of gut bacteria, most commonly E. coli. But in general, it's going to be enteric gram-negative. So our old tried and true ceftriaxone is more than sufficient here, but any third generation cephalosporin should provide sufficient coverage. Usually these folks you're going to treat for 5 days of IV antibiotics and then transition to an oral fluoroquinolone. Now, don't forget, once a cirrhotic has had one episode of SBP, those patients generally need lifelong prophylaxis with antibiotics. Okay, so once they're transitioned to their oral Cipro or whatever, they'll be on that kind of indefinitely. Okay, so albumin. Albumin is really critical in SBP. It significantly reduces mortality, and it's given on day 1 and day 3. And the reason it significantly reduces mortality is it reduces the incidence of hepatorenal syndrome, or it reduces the severity of hepatorenal syndrome, which is usually how patients with SBP die. So there was this landmark study that came out in 1999 that took a look at SBP patients, and it cohorted one group into antibiotics alone and the other group into antibiotics plus albumin. In the antibiotics alone group, 41% of the patients died, compared to the albumin group, where only 22% of them died. So still, SBP has a really high mortality, like I've already alluded to, but giving albumin significantly reduces mortality. Okay, so you can't forget about this. As I mentioned, we don't give albumin routinely, but if you've got a reason, i.e. SBP, or you performed an LBP, they got to get it. Okay. So I keep mentioning hepatorenal syndrome, which I think is something that we don't always have a great grasp on. It's a little tricky to diagnose sometimes. I kind of briefly covered that. So cirrhosis, as I've mentioned, results in this very disordered cardiovascular blood flow. These patients tend to have a lot of blood that just hangs out in the mesenteric vasculature. So I don't know an exact percentage, but a fair percentage of all their blood is just hanging out in the portal venous system. And because that blood's just hanging out there, that means it's not circulating systemically, all right? And so if it's not circulating systemically, our kidneys are thinking, there's a problem with our pressures, and through the renin-angiotensin-aldosterone system, in an attempt to raise those pressures, you're going to get renal artery vasoconstriction, trying to increase the intravascular pressure. In reality, though, what's happening is that this vasoconstriction is really reducing the blood flow to the kidneys. So in an attempt to make things better, the kidneys kind of strangle themselves, and it's a vicious cycle. They sense hypoperfusion. There's renal artery vasoconstriction. There's more hypoperfusion. There's more vasoconstriction until the kidneys die, and that's how the majority of these patients will die. This is the same reason that these patients get hypovolemia, or hyponatremia. The body is sensing functional hypovolemia. So it's not necessarily true hypovolemia, but there's functional hypovolemia because all the blood's within the venous system, and thus our brain is going to release antidiuretic hormone, resulting in the kidneys trying to hold in more water, causing the hyponatremia. So we talked a lot about the RAS system and antidiuretic hormone in our heart failure lectures and the our sodium and water lectures. It's a really important concept to me, the things that people struggle with in internal medicine all go back to the renin-angiotensin-aldosterone system, and ADH. If you've got a good handle on that, you can handle some of these things with really complex physiology. All right, so go back and watch the heart failure lecture, which we spend most of the lecture talking about it, and the hyponatremia lecture. And it's a really important concept. Okay, so in both of these cases, our patient was altered, right? And so next we're going to talk about hepatic encephalopathy, which brings me to my second take-home point. Remember, our first take-home point was any patient with cirrhosis with ascites that comes in with any problem has SBP until you prove that you don't, or until you prove that they don't. Take-home point 2, hepatic encephalopathy is a sign of another problem you have yet to diagnose. Okay, so obviously you've got to treat the elevated ammonia because that's what's causing the altered null status, but you've got to figure out what has precipitated the hepatic encephalopathy, because those things are deadly, again, if you miss them. So if there's something dangerous going on and you've loaded their ammonia and they still die because you didn't treat that dangerous thing, you haven't really done much of a favor. So with all of my patients that come in with hepatic encephalopathy, I use this acronym to help me run through everything I need to be thinking about. And it also kind of helps you determine what workup you might need to send. So it's CCC liver, which is compliance, medication compliance, mainly lactulose. Constipation, which is often due to not taking their lactulose, but not always. Cancer, specifically HCC. Librium is kind of a placeholder for all bad habits, benzos, alcohol, drugs. Infection can do it, SBP most commonly, but these folks get other infections too. Volume is a big one. And a lot of times we do this. So maybe we've over-diuresed them and they're dehydrated, or maybe we've given them too much lactulose and they've had too many bowel movements, or maybe they've recently had a large volume paracentesis. Sudden shifts in volume can lead to hepatic encephalopathy. Electrolyte abnormalities can do it too, most commonly hypokalemia, and then RBCs, which kind of stands for GI bleeding and portal vein thrombosis. So although most of our cases is probably due to lactulose noncompliance, you're doing yourself a disservice if you immediately attribute all cases of hepatic encephalopathy to lactulose noncompliance. So be thinking about this. So, you don't necessarily have to do an ultrasound on every patient that comes in, but if you've got a cirrhotic that comes in and it's been 2 years since you've scanned him, maybe we should make sure he hasn't developed HCC in the meantime, or maybe he's developed this portal vein thrombosis that's just kind of slowly progressed to the point where it's now reducing blood flow. You probably need an ultrasound on most of these patients. Are they having a subtle GI bleed? Did they recently have an increase in their diuretics? Are they still drinking alcohol? Are they taking benzos? Is there an infection? Again, if they've got ascites, they've got SBP until you prove that they haven't. Okay, so remembering this acronym will kind of dictate what workup you send. Okay, so one of my pet peeves in medicine, don't check an ammonia level. Okay, so another take-home point here, we all know this, but as a reminder, hepatic encephalopathy is a clinical diagnosis, not a lab diagnosis. Okay, so in other words, if you have a decompensated cirrhotic that comes in with encephalopathy, he has hepatic encephalopathy, period, end of story. Okay, don't check an ammonia. Regardless of what the ammonia level is, you still treat him for HE. If the ER checks it or the admitting team checks it, ignore it. I don't care what it is. If they're cirrhotic and they've got encephalopathy, you treat it as hepatic encephalopathy. Okay, on the other side of the coin, if you have a cirrhotic who's functioning well and has no issues and their ammonia is high, I ignore it. So ammonia is, to me, I can't really think of a scenario where ammonia is ever helpful in a cirrhotic. Don't order it. Okay, it just creates confusion or a false sense of diagnostic certainty. Now that doesn't mean ammonia levels have no value. Okay, for me, where an ammonia level is clinically helpful is in the setting of unexplained altered mineral status in patients without known cirrhosis. Okay, so you've got a patient that comes in and they're altered. Checking an ammonia is helpful because if that's elevated, then you need to say, well, maybe she's got undiagnosed cirrhosis. Let me go looking for it, or maybe she's on a drug like Depakote that can raise the ammonia. So in confused patients without known cirrhosis, check the ammonia. If you've got cirrhosis, don't check it. Okay. All right, let's talk about treatment. So as I've kind of alluded to, there's two things here. We got to lower the ammonia. Everybody does that. Nobody forgets to do that. It's the first thing that people forget. You've got to go looking for the underlying precipitant. In most cases, it's going to be non-compliance, or it's going to be because they're drinking again. But just be really careful. You don't want to be blasé about attributing a precipitant to HE. If you miss SBP, they're going to die. If you miss a GI bleed, they could die. Okay, so you've got to be really careful about taking time to think through other possible causes. Right. Mainstays of lowering the ammonia, lactulose is the go-to. It works by binding the ammonia within the gut, allowing the patient to poop it out. If the patient's too altered to take anything PO, lactulose enemas work well. This is a drug that you got to spend a lot of time educating your patients on. Pretty much anytime you're seeing a cirrhotic, you need to talk to them about their lactulose. It doesn't taste good. It's makes them go to the bathroom several times a day. There's a lot of non-compliance with it. Just emphasizing the importance of it and emphasizing how poorly patients who come in with HE do is critically important. The rifaximin is also a key player here. So rifaximin is a non-absorbable antibiotic that kills the bacteria in the gut that produces the ammonia. The more and more literature that comes out about rifaximin, the better it looks. It really is a great drug. There was a new study that just came out a couple of weeks ago looking at post-TIPS hepatic encephalopathy that I alluded to, and patients who were treated with rifaximin did significantly better. Okay. This is also an expensive drug, but if you order the rifaximin power plan and impact, it will send a consult to the specialty pharmacy, which will then investigate ways to get this drug, whether they're uninsured or they've got Blue Cross. Okay. It's not a replacement to lactulose, but it is an adjuvant drug that most patients should probably be on. And then lastly, the literature is not as good for zinc, but there's little to no downside to giving a mineral. I pull the trigger on zinc when there are severe cases of HE or if the patients are kind of slow to respond. And it works by converting amino acids into urea instead of ammonia. So it's not a huge player, but it's something I kind of throw on after I've done these other things. Okay. All right. Things to remember. Do not give albumin routinely, but it's okay to give it in cases where there's evidence, okay, like SBP and LVP. There's rarely a reason, i.e. never, a reason to order an inpatient hemocold test. Okay. This one, the next two are the biggest ones here. Any cirrhotic with ascites admitted for any complaint whatsoever has SBP until you prove that they don't. Hepatic encephalopathy is a sign of another problem you have yet to diagnose. Don't forget that. Don't be lazy and attribute it to something like, oh, he didn't take his lactulose yesterday, even though that's usually the cause. And then lastly, hepatic encephalopathy is a clinical diagnosis. Do not check an ammonia in a cirrhotic patient. All right. Okay, that's all I got. You guys have any questions for me? Anybody? See if something come up in the chat. Okay. All right. Well, we will get this uploaded to the YouTube channel, but if you have any questions later on, let me know. And thanks for joining me. I appreciate it. See you later.